Hi, my name is Dr. Mazahery. I'm an orthopedic spine surgeon at resident office from OrthoVirginia in Northern Virginia region. We've been with the practice for 20 years, and today I want to talk about back and leg symptoms and some of our surgical approaches and the ways we manage this, because patients ask me all the time, why do you go from one direction or another, and what's the difference? So kind of give you an overview on that. Typically in the world of back and spine surgery, the question is it a back pain or leg pain? And it's just more leg pain and someone has a pinched nerve. And in that scenario, we can just unpinch a nerve as long as we don't destabilize their spine. That's all they need, is something that we can do as an outpatient, either a discectomy or a laminectomy in patients who wake up with their leg symptoms completely resolved. When it's back pain, the question is it structural back pain? And is there something rubbing? Is there alignment off? Is something shifting? Is there instability? And if there's signs of instability, then unfortunately what we have to do is a bigger surgery where we stabilize someone's spine with a fusion. And so there's different people say, well, why do some people go to the front, some people go to the back? And I want to show you some models of what the different approaches has and the pros and cons in the short term about this. This is called the ALIF, anterior lumbar interbody fusion. And sometimes when a disc is rubbing bone on bone, or if someone has lost their curvature in their front, or if we want to get great structural support at the bottom of the spine at L5S1, because that's where the basement of the back is, we have to go in from the front. And from the front is actually less invasive. All we do is cut skin and everything else kind of moves out of the way. We need an access surgeon oftentimes to do that. But once we get there, we take out the disc and you can see we can put a large size spacer that prevents rubbing of the bone against this. It also allows us to push things back to where they belong. And most importantly, it allows us to get the curvature. So you can see the curvature is restored. When the bone is collapsed bone on bone, your lower back curvature is flat and it makes you to lean forward, which is also hard to fight gravity over time when you're leaning forward. But the nerves are in the back, so we can't clean up the nerves as well doing this. We can do that to create foraminal height restoration. But we want to directly unpinch the nerve. Sometimes we gotta go from the back of the spine. And when we go from the back of the spine, the nerves are where my finger is, and we can unpinch that. But when we do that, we have to put in now screws and rods if there's signs of instability. And the screws and rods avoid us to do another procedures. When you do this, sometimes we use what we call a TLIF, which means sometimes we put in a smaller spacer because we have to work around the nerve and put in the spacer. And sometimes we can't go to the front because of the abdomen or the structures in the front. So we have to come in from the side. And from the side, that's called a extreme lumbar or a lateral interbody fusion. And basically we put in a spacer like it shows here, where we're coming through in a minimally invasive retroperitoneal approach into that area and put in the spacer to restore the disc height and give us structural support. So we can go from the front, we can go from the back, we can go from the side, and they all have different pros and cons. And typically if we can come from the front and the side, we avoid muscle dissection. So it's an easier recovery and it gives bigger structural support and improves their curvature much more when we do that. And sometimes we have to combine all of it in order to get the alignment that we want and achieve the surgical goals of unpinching the nerve, as well as getting the spine to the appropriate alignment. I hope that helps. Please contact us if you have any back or leg symptoms that is failing conservative management.